The next presentation will be delivered by me. I am Dr. Meghna Roy. I have done my MBBS and MS from Regional Institute of Ophthalmology, Banaras Hindu University, Varanasi. Currently, I am doing fellowship in anterior segment from Nirmal Ashram Eye Institute, Rishikesh, Uttarakhand. I will be speaking on prognostic significance of ocular trauma score. I have nil financial disclosure. As we all know, once described as a neglected disorder has recently been highlighted as one of the major causes of monocular non-congenital visual impairment and blindness worldwide. 50% of the attendance in eye casualty cases is of ocular trauma. Worldwide, 2.4 million ocular injuries occur each year. Among them, 5 lakh result in blindness every year. 1.6 million people are blind due to ocular trauma, which constitutes 4.4% of total blindness. 2.3 million are bilaterally visually impaired and 19 million have monocular blindness. Open globe trauma is a major cause of permanent visual impairment. Rupture globe represents one of the most serious types of open globe injury, which is associated with very poor prognosis and requires immediate surgical repair. The major cause of open globe trauma are road traffic accidents, violent attacks, high fall injury. Urgent management and subsequent follow-up is important to maximize recovery of open globe trauma. Visual outcome is generally very unpredictable because it not only depends on the anatomical structural damage, but also on the functional recovery, which is based on individual patient, surgeon, and other risk factors. And there have been numerous controversies in the past due to the variability of practice standards, the relevance and practice of the ocular trauma score to highlight validated and effective predictive model in both adult and pediatric ocular trauma was really very helpful. This is the general classification of ocular trauma, which is local, non-mechanical, mechanical, which includes thermal, chemical, electrical, radiational, ultrasonic as non-mechanical, and adnexal and global as mechanical. Adnexal is further classified to eyelid, orbit, and conjunctiva, and global into structural and pathological. Associational injuries such as head injury, facial injury, polytrauma may be associated, and environmental include industrial, recreational, RTA, criminal, and agricultural. Now coming to the history, Ocular Trauma Classification Group was convened in 1997 by Pierre Missy et al. Next in the year 2002, Kuhn et al., after analyzing more than 100 variables for over 2,500 eye injuries recorded in United States and Hungarian Injury Registry, formulated the ocular trauma score. It is used to predict the visual outcome of patients after open globe injury in order to identify the best predictors of outcome at 6 months after injury. It is the single most widely known ocular trauma prognosticating tool. After reviewing ocular trauma classification systems in ophthalmology and general medicine, Birmingham Eye Trauma Terminology System was finally developed in the year 2004. This is the Betz classification, in which mechanical injury is classified into closed globe injury and open globe injury. Closed globe injury further into contusion, superficial foreign body, lamellar laceration, and open globe injury into laceration and rupture. Laceration further classified to penetrating injury, intraocular foreign body, and perforating injury. The ocular trauma score system is used to determine the severity and prognosis of ocular injury, and it depends on initial grade of visual acuity, status of RAPD, types of injury, whether it is rupture or perforating injury, and complications such as retinal detachment and endophthalmitis. Classifying it into zones, Zone 1 in open globe injury is isolated to cornea, including the corneoscleral limbus. Zone 2 is from limbus to point 5 mm of sclera, and zone 3 is posterior to the anterior 5 mm of sclera. In closed globe injury, zone 1 is external, that is limited to bulbar conjunctiva, sclera, and cornea. Zone 2 is anterior segment up to pars plicata, and zone 3 is the posterior segment, all parts behind posterior lens capsule. The ocular trauma score analyzes 6 specific variables, and it is used to counsel the patients and their families to manage their expectations. It provides guidance for the clinician before pursuing complex, sometimes expensive interventions, especially when the resources are limited. In OTS, the score ranges from 1, that is most severe eye injury and worst prognosis at 6 months follow-up, to 5, that is least severe injury and least poor prognosis at 6 months. Each score is associated with a range of predicted post-injury visual acuities. It has a predictive accuracy of approximately 80%, which means that the ocular trauma score will be accurate 4 out of 5 times. Now, how to calculate the ocular trauma score? When the patient presents to us with trauma, we will first assess the visual acuity of the patient, and based on that, we will calculate the initial raw score. If the person has no perception of light, then we will give 60 points. If there is PL or hand movement, 70 points, and so on. If there is globe rupture, then it's minus 23, and the endophthalmitis minus 17, followed by perforating injury retinal detachment RAPD. Then we will calculate the raw score sum, that is sum of raw points. And based on this raw score, we will classify into different categories. If the total score is less than 45, it is category 1. If it is 45 to 65, category 2. And the highest score in OTS category is 5, that is 92 to 100. Minimum score is 15 and maximum score is 100. The higher the score, the better the prognosis of the patient. And after that, according to the OTS score, we will see the probability of follow-up visual acuity category at 6 months. And it is seen that if the OTS score is 5, then the probability of visual acuity is best, that is 92%, greater than 20/40. And the patient has the best prognosis. Coming to the pediatric ocular trauma score, the OTS has been beneficial in pediatric ocular injuries as well. The value of the OTS for predicting visual outcome following surgery in children with traumatic cataract has been validated in several studies across the globe. There are very few reports comparing predicted and achieved visual acuities prospectively. Most of them are retrospective studies with contradictory results. There are several drawbacks of this OTS, so the pediatric ocular trauma score was formulated. POTS is more sensitive and specific in case of higher raw scores. It does not predict outcome as accurately with lower raw scores. Inability to assess the presence and severity of RAPD and the potential development of amblyopia in younger children is quite challenging. Because the patient also has strabismus refractive error or ocular opacity, so it can result in amblyopia. If the possibility of amblyopia is not included in the score, then the predictive accuracy of OTS may be compromised. The authors have hence incorporated this into the OTS to derive a mathematical model for the pediatric ocular trauma score. Limitations of ocular trauma score. It does not include associated injury that have a bearing on the outcome of the mechanical injury, such as it doesn't include chemical, electric, and thermal ocular injury. It does not include significant facial as well as ocular adnexal injuries. It does not factor in results from ancillary tests, including X-ray, CT scan, or ultrasound, B scans, that inform the examination of the eye, especially when there is no view of the posterior segment. So the clinician has to interpret these other clinical and investigational findings to help refine the prognosis predicted by the OTS. So conclusion is that OTS is good. An accurate predictive model may be used to predict visual outcome in all types of mechanical eye trauma. It can be used as a reference point by clinicians when auditing surgical results of cases due to trauma. OTS also has a good predictive value in case of pediatric age group, but POTS is better for this purpose. It is helpful in early assessment, life stabilization, early primary intervention, and additional intervention. It is simple, and so even the medical and nursing staff with varying level of experience can understand the prognosis. It is an appropriate aid for counseling and reduces unrealistic expectation of the patients. Thank you.